Hi everyone, thank you for coming today. Shahid, yes, if you can say something so we can test the audio. Hi, can you please say something? I'm getting a lot of noise, but I'm not getting any speech from you. Hi Shahid, we're getting a lot of noise, but nothing else. Can you please change your microphone? I can see that you're unmuted, but there is nothing. I can hear nothing except a bit of noise. Do you mind changing your microphone, please? Apologies, everyone. We're just going to try and sort out the technical issues we're having, and we'll be with you very shortly. Hi, everyone. Sorry about the delay. If you can be patient for a few more moments, please. Okay, let's try this again. Shahid, do you mind unplugging yourself and unmuting?
Yeah.
Yes, there we go.
Okay. Okay. Perfect. Thank you. Sorry about the delay. Okay. So hello, everyone, and thank you to the research app team for inviting me to present this important topic on nephrotoxic nephritis, glomerulonephritis, animal model versus human disease, and this is a presentation in collaboration and linking with the Renal Patient Support Group, the RPSG, and in support of World Kidney Day 2022. And the main theme of World Kidney Day this year, just to highlight, is around kidney care for all, and that's slide one. I'm now moving on to slide two. So a bit of introduction about this topic. So research with animal models has shown the crucial interaction between certain inflammatory cells and cells intrinsic to the kidney that is both fundamental and unique to the pathogenesis or the pathology of glomerulonephritis. Now, the term glomerulonephritis basically encompasses a range of immune-mediated disorders that cause inflammation, and the main terminology is where glomerulonephritis is concerned, inflammation is linked with that, and within the glomerulus, which are the functional components of the kidneys, and the mechanism of interaction between these cells and the mediators of their coordinated response to inflammation are being elucidated. So despite these pathophysiological advances and in areas of laboratory practice and pathology, treatments for glomerulonephritis remain non-specific, can be hazardous, and only partly successful. Now, therefore, glomerulonephritis and glomerulonephritis throughout this presentation will be abbreviated as GN. Therefore, GN remains a common cause of chronic kidney disease globally. So moving on to slide 3. So here, I'm going to just talk a little bit about the mechanisms. Now, the mechanisms in this context is where evidence of complement is something in relating to the immune system, and in relating to parts of the immune system where it's linked with immune related diseases. So evidence of complement deposition within the glomerulus is a key feature, or is one of the main components that forms a glomerulonephritis, or GN. And the role of complement in this context is implied by several observations in human disease. Now, indirect evidence obtained from human studies has been supported by findings in animal models. And now, when we're referring to animal models, and there will be a slide around this, but just a heads up, when in related to animal models overall, in relating to kidney care and treatments, and relating to different kinds of treatments, the main animal models are murine type mice models, or rat type animal models. But we'll get into that in the next few slides. So the mechanisms by which macrophages mediate renal injury remains to be confirmed, but it is likely to include promotion of inflammation via release of pro-inflammatory cytokines such as tumor necrosis factor, or TNF, and recruitment of macrophages and other leukocytes or white cells through or via release of chemotactic molecules. Now, chemotactic molecules include a monocyte chemotactic protein, protein type 1 or MCP type 1, and cell proliferation by release of growth factors such as macrophage colony stimulating factor, which is an abbreviated as MCSF. And these have been established. Now, cell death as part of the mechanisms and in relating to GN, cell death occurs through the release of reactive oxygen species, including nitric oxide, and control of fibrosis and repair via release of various enzymes. And now I'm going to move on to the next slide, slide 4. So a little bit of epidemiology and background relating to a GN, and in this context relating to in bringing understanding around the animal models and human disease aspect a bit more. Now, from an epidemiological or statistical basis, population-based screening studies have shown that evidence of kidney damage by proteinuria, which is referred to as where there's protein leaking through the kidneys, hematuria, which is basically where there is evidence of blood which is being voided through urine, which is not usual, although calculated glomerular filtration rate, or GFR, or a combination of these features is present in about 16% or just less than 20% of adults in Australia, and a similar proportion in the USA. Now, this is there will be a list of references and sources at the end of this particular presentation. So I will highlight where more understanding can be sought through the literature around this particular context. Accurate classification requires a histological diagnosis, and consequently the reported prevalence might vary according to local indications for renal biopsy. Now, renal biopsy, as some may know, for example, is a basis to try and identify different forms of scarring, or why, for example, someone may have a form of glomerulonephritis, on why glomerulonephritis has occurred. Now, a retrospective analysis of all renal biopsies performed between 1995 and 1997 in the Australian state of Victoria during 1995 and 1997 found that around 21 and a half or 22 people, around about 22 people per 100,000 population per year underwent a form of renal biopsy, yielding an annual incidence of biopsy proven GN of 12.3 per 100,000 in the population. So on a sort of from an epidemiological or population health perspective, basically almost 10%, or sorry, just over 10% of the population, which might not seem a lot, had a form or were at risk of having a form of glomerulonephritis. Now, the most commonly diagnosed types of GN in adults were IgA nephropathy, something referred to also as focal and segmental glomerulosclerosis. Now, and also vasculitis. Those most commonly diagnosed are actually in young people, and pediatrics and young people were minimal. Were also forms relating to minimal change disease or minimal change, focal and segmental glomerulosclerosis, lupus nephritis, and also IgA nephropathy. Now, when you add up the different forms of GN, then GN across population, basically you can see that generally speaking, there is a kind of misnomer when looking at GN across different populations, and so the statistics are pretty preliminary, and what clinicians and scientists don't really know is the full extent of GN, globally. But we know that it is a problem. So now moving on to slide 5. Now, a little bit about the pathogenesis. So the pathogenesis of GN is quite complex. The intricacy arises from factors such as autoimmunity, so where particular immune cells, as part of physiology, attack itself, attack or cause a prompt to cause an immune response, so that the cells cause are doing more harm than being protective. So factors such as autoimmunity, cancer, and structural abnormalities within the kidney or kidneys. Now, there is variability in the susceptibility to GN, which is likely to have a genetic basis as well. And there are also complex interactions between soluble factors, including antibodies, complement, chemokines, cytokines, and growth factors. Now, all of these certain terminologies I mentioned, for example, antibodies, complement, chemokines, and cytokines, and growth factors, generally in the realm of research relating to kidney care practice or nephrology and scientific or laboratory practices. These particular cells are perhaps the most prominent cell types that are studied under close investigation when looking at GN, and also where I mentioned, for example, different forms of other cell types. For example, those two, for example, MCF. Or MC, and also MCP type 1 and other cell types, all are closely linked not just to GN but other forms of kidney disease. So generally speaking, when investigating, when researchers and scientists and clinicians are investigating around different forms of kidney disease and not just GN, generally the pathogenesis relate very much to these cells being under close investigation all the time. Now, in line with this, the contribution of non-specific factors such as hypertension or high blood pressure or proteinuria or protein leaking promote continuing kidney damage. Now, protein leaking is a very primitive a link to where kidney disease can occur. Now, the issue with proteinuria is not so much in the first place where there's protein leaking through the urea. That's not much. That in the first instance, that's not the main issue. The main issue is actually when there is protein leaking or proteinuria, there normally is or can be reflux that is attached to that, and that when reflux happens, it's then where patients, especially those with, for example, weaker immune systems, where they have reflux, and that can cause damage to the urinary tract, and that is why proteinuria can be problematic. Now, generally, despite despite the sort of some of the advances in certain aspects around pharmacotherapy, for example, there can be continuing kidney damage or renal damage despite resolution of the initial insult. And a constant feature of GN is the presence of as I briefly mentioned, inflammatory leukocytes, inflammatory cells, including leukocytes within the glomerulus of the kidneys and the interstitial compartments of the kidney. Now, macrophages are important again, and T cells are T lymphocytes are also important in relating to the dominance they play in the pathogenesis. Now, they're important because these cell types are not just present, but they also have there is also intensity of how their presence cause cellular damage in relating to how these cell types can accumulate where GN exists, particularly with the institutium, rather than the glomerulus. So where GN is concerned, it's primarily the glomerulus is the main part, or the main area that is affected. But with the glomerulus, there are other areas that extend parts of that as well. So basically, GN is where there is the first basis of where this disease can occur. Where insult and injury can occur, but then thereafter there is problems where other areas of other functional parts of the kidneys are also are susceptible to damage. And so along with the institutium, rather than the glomerulus, has repeatedly been found in research to correlate with the clinical and pathological severity of disease in animal models and in human beings. So there's a link between those two focuses. Now, I'm going to move on to slide 6. So a little bit about the actual basis around the animal models now. Now, 3 main points here on this slide. Number one, animal